Hello, everyone. Thank you for having me. My name is Sheila, and I'll be talking about Post Concussion Syndrome, more than a normal CT. I'd really like to thank the organizing committee for this opportunity. So I'll start off with a letter that was uh, written from a GP who was managing a campus clinic in a local university. So it starts off with a reference for Miss C. Who's had a post-concussion syndrome. He writes, "Dear Dr. Sheela, thank you for seeing Miss C, who's an undergrad student in the university. A couple of months ago, she had a fall down the stairs in the main building. She had a loss of consciousness for less than 10 minutes and was dazed, after which she didn't have other injuries. She was seen in the campus clinic twice, and once immediately post-fall and follow up at 1 month. She had reached out as her symptoms were interfering in her assignments and her social life. She had headaches, almost like migraine-like. She was blanking out during lectures, having trouble focusing, and when it came to the due date for her assignments, she had trouble sending it in on time. She also had problems sleeping and didn't like to go out socially. She was given paracetamol, but she took it when she felt that she needed it, and it didn't quite help her. And he felt that she was having post-concussion syndrome and referred to us to do some assessments and perhaps give us some strategies to manage her cognitive, emotional issues as well as managing her headaches. Okay, so today we talk about a short introduction into rehabilitation, into multi-BI, introducing what post-concussion symptoms are, what are cognitive issues that they can have, some of the strategies to manage post-concussion syndrome, and then we conclude. So basically rehabilitation medicine as a whole is all about function. So we are people who manage and we work as a team. And for one patient, there'll be numerous people working with that one patient. We have physiotherapists, occupational therapists, speech therapists, rehab physicians, rehab nurses, psychologists, social workers, a whole group of people. Okay, so we've managed function in terms of trying to prevent any loss of function, slowing the rate of functional loss. We try to improve or even restore, we compensate, and we try to maintain. So if you have a child who is born with CP, then we'll try to improve their function because it depends on the level of CP that they're born with. We try to improve it, okay, as they grow. And if somebody who has for instance, ALS, then we try to prevent further loss of function and giving them the optimal functional chance that they have at that current level. And we try to slow it down. Okay. And if somebody who is progressively becoming worse, like I mentioned, ALS, even MS or Parkinson's disease, might need some help in managing their current level of function. Okay. Sometimes we give them aids and adaptations such as a walking aid or even certain things to use with their hands to help them manage the ADLs better. Okay. Now, if somebody's had a stroke, then we want to improve them functions. Let's say they're hemiplegic, they're bound on the bed. We'll try and get them to move on the bed, sit up, and then get onto the wheelchair and start standing and start walking. Somebody who's had an amputation, we'll try and compensate with a prosthetic limb and train them on how to use it. So we work as a team. We cannot work in silo. And because we work as a team, we all have to have the same goal. We can't be working different goals with the patient or confuse the patient. And so we have to meet often and communicate well so that we know that we are having the same um, goal. Okay, so now before we start, and because it's all about interventions, so the physio have its own group of exercises to let this patient sit up. The occupational therapist will have its own group of exercises to teach the patient how to take care of his activities of daily living, such as brushing his own teeth or even taking his own bath. So they have their own set of interventions. Now, each time they do a set of intervention, they formulate a goal, and they also formulate a certain amount of way of measuring their level of function before carrying out this intervention. So that's what we call as outcome measure. So we sort of assess them before, and then we carry out all these interventions, and then we assess them after. So throughout the entire process, it's communicated out as often as possible, as often as once a week. And each time there's a change in the management, the other team knows what's happening. Okay. Okay, so now we go ahead and define what concussion is and what is multi-VI. You've probably heard this in the previous lectures, but I'd like to just point out to you that it's an acute neurophysiological event. So that includes some amount of physiological change that's happening in the brain that we're just beginning to understand. There can be stress around the neurons, strain or tearing of neurons or axons. There can be changes in the chemical level, biochemical level, neurotransmitters release and breaking down of proteins that's happening. Okay, so we're just beginning to understand multi-VIs. So any blunt impact or mechanical energy that's applied to the head or neck or body or transmission of forces that translates into the brain. Okay, it can be sudden acceleration, deceleration, rotation of forces. So you're thinking sports injuries, you're thinking falls, assaults, or even motor vehicle accidents. Okay, so now you've seen them in moderate and severe, but in mild, it's different. Okay, so in mild, they usually loss of consciousness less than 30 minutes. And you can have some amount of memory, loss of memory around the events immediately after the injury. Okay, so less than 24 hours. And they can have a change in mental state where they will be confused or dazed and disorientated. And they may have slow in their thinking. So we'll look a little bit more in detail about this aspect. They have physical symptoms such as headaches, even vestibular issues, which means more of dizziness and hand, like eye, vestibular, ocular movements are an issue. There's a loss of balance, change in vision, or even if they become more sensitive to any auditory stimulus. So somebody screaming would be something that they could have managed before. Now they are unable to manage it. Bright lights are a problem. Glares are a problem. Yeah? So there's no, if you look at the CT, usually the CTs are normal. Now, we are kind of confined to CTs because in the emergent care or even in the GP setting, we just go for a CT to look out for any other lesions, right? But most of the time they turn out to be normal. They may not be the best imaging that we can use for post-concussion syndrome, okay? So you know the severities, I don't have to tell you this, but if you look at multi-VIs, you know that there's something that I want to highlight is post-traumatic amnesia, less than a day, and LOC is less than less than an hour, 30 minutes. Okay. So just to recall what the brain function looks like. So if you look at the brain, you have the different lobes. Apart from looking at the CT scan, you can see that you have the frontal lobe, the parietal lobe, the temporal, occipital, cerebellum, brainstem. So they all have their own function. Okay, so the frontal lobe essentially works for behavior. It regulates behavior. It has a role in memory. It sort of like builds a person's personality. The IQ and intelligence comes there. It's like the CEO of the brain. So it reasons out, it plans movement, and it sort of conducts everything well. Okay, and then next to it is the parietal lobe. It also has a lot of intelligence, more of sensory comes in, a lot of sensory analyzing of what sensations people feel, knowing right to left, identifying right and left orientation, someone of language interpretation and reading. Below that, the other side of it is the temporal lobe. That is also very important for memory, regulation of emotions. Now, that it's dependent on the frontal lobe to guide its emotions better, and vision, as well as some amount of speech. This is where you divide it between Broca's aphasia and Wernicke's aphasia. So this is more of a Wernicke's, okay? And then there's the occipital lobe, which is basically the vision cortex. It tells you what it sees. As long as the pathways are normal, it tries to interpret what it sees, perceives what it sees. Okay. And the cerebellum is mainly for coordination, balance, and fine motor control. So because we don't know what's happening in multi-VI, so any one of these areas can be affected. Okay, we think that is mild because they're maintaining the conscious level, mainly because the brainstem is still intact. So therefore, the conscious level still remains. Okay, so but there are areas in the frontal lobe, some areas in the parietal, some areas in the temporal lobe that may have been injured to some extent. Okay. So then we look at, okay, yeah, so if the CT scan is normal, MRIs may or may not show something. What do we do? How do we know? Is the patient for real? Is he serious? That kind of thing comes into our mind. Okay. So if you do a PET scan, so we know a PET scan looks at brain metabolism. Okay. So if you look at his normal brain, you can see that there are areas of orange and red and yellow. That shows where this amount of uptake of glucose and all is greater in this area. Okay. So you can see a normal brain is always thinking. The frontal, the parietal, temporal, it's always thinking. Okay. It's always lighted up. So these are the areas which is normal in a normal individual. Now, if you look at a CT of a PET scan of a severe head injury, you will find that these areas are not lighted up because they have been temporarily out of order. So they don't light up just as well. In fact, they're just greens, okay, and more blues, which means the flow of blood to these areas or even glucose uptake to these areas are less. So which means they are, you can imagine a severe brain injury, how dull they are, okay, and how impaired they are cognitively. Now you see a mild TBI compared to the severe, it's not too far away from it. You don't find any reds or greens that shows up in a normal PET scan. So that gets you to wonder, perhaps this patient does have a problem in the frontal area, which doesn't light up well. Parietal doesn't light up as well as a normal. Temporal and vision. So what are we dealing with actually? Okay. So then you can see that because of those areas of the brain that's involved, you can divide them into physical problems, behavior and emotional problems, cognitive issues, and perhaps sleep issues. So physical, if it's the frontal cortex that's having an issue, you can have headaches, you can have problems with balance if it's the cerebellum, some sensitivity to light and noise when it comes to the occipital as well as blurred vision, some ringing in the ears if it's the temporal. Okay, and they can also have behavior issues, irritability that can be also temporal, the same with depression, the same area. All of these tend to be in the temporal and frontal cortex. Okay, lack of initiation, lack of drive. Sometimes you just sit there waiting for things to happen. The days goes on for days. Okay, and there's impaired awareness of what's wrong with them. And they may have cognitive issues, feeling in a fog, they're unable to focus, they blank out, they have problems remembering. That means they have problems with their memory, finding the right words, and they're saying something, they know the word, but it sort of like disappears on them. Okay. And when they're in a noisy environment, they can't quite filter out what a person is saying. So if we're all talking loudly and we're trying to concentrate on somebody, normally we have the attention process to be able to concentrate on the other person, even in a noisy environment. So this can be impaired in a mild TBI. They have problems sleeping, okay, maintaining sleep, falling asleep, and have too much of sleep sometimes, okay. They don't feel refreshed once they fall asleep. So sometimes there is some amount of fatigue that comes into mild TBI as well. Okay, so then you ask me, yeah, so how often does that happen? Now, most of the TBI with literature that's been scanned through by WHO, about 70 to 90% of TBIs are mild in nature. Okay, and how often do these have symptoms of these mild TBIs have post concussion symptoms? So at first few weeks to a month, they get about 40 to 80% of them have symptoms. At probably 3 months, 50% of them still have symptoms. At 1 year, they can reduce to 10 to 15% of them. Okay. So what are the symptoms of concussions, concussion problems, right? We've already been discussed as well before this. They have problems sleeping, really said that. So in a nutshell, in an infographic, you can keep this, in your ED so people are aware, you can have this as like a fog in their brain. I can't think clearly. I have problems trying to react, so people ask you a question, you take time to answer, okay? And then there's the cognitive part, and you have emotions. Sometimes you just get very, very irritated. Impulse buying comes in, like Shopee. We have a problem with Shopee already, right? We keep buying. Now it becomes even worse, okay? And then you become even more sad, more anxious about everything, okay? They can't keep their head, they can't, keep their head being pain-free. It's always in pain. They can't recall the accident. They're just not rested when they sleep. Okay. So what can you do in the ED? You can do something called Westmead PTA scale. This is the abbreviated one. So you can see this first tree is all about GCS, and you know GCS, and don't have to go through that. But later on, there's also something called recalling of pictures. We'll show you a set of pictures, and we'll ask you to remember this. So we show it to you, and then we'll ask you again within 5 minutes to remember these things. Okay, you're scored accordingly about the GCS scoring, and then we'll try and also ask you a few questions on orientation about the name, place, where you are at right now, what's the month, and what's the year. Okay, so yeah, so you can see it comes with some how to administer them. So what's your name, where are you at, why are you here, what month are you in, what's the year. Okay, and you recognize these pictures that I'm showing, and you can put them in a T1, T2, T3, T4, T5, that means the time. So it can be half an hour, 1 hour, depending. Okay, so if you show them these pictures and you ask them again, do you remember these pictures at T1? Or T1, you can't ask them because that time when you're showing the pictures. So half an hour later, you ask them, do you remember these pictures? Can you name them? Okay, and then can you name me the pictures that I showed you? Okay, so then if they get it all right, that means they're out, they're no longer in PTA. They should score 18 out of 18 to be out of PTA. Okay, if they are still in PTA, that means they need to be educated that they are having concussion symptoms, and when they do go back home, then perhaps we need to give them something to know what signs when it is to come back to the hospital. Okay, so to give you an idea what PTA is, this is more for mild, not so much for mild, for more for moderate and severe. So let's say the event of the accidents around February 14, and he had the accident and brain injury, and he's in ICU. Okay, and then he somehow months or maybe a year down the line goes back to work. So, and then all go back to school. Then you ask him, do you remember the event? He says no. Then you ask him further, do you remember Chinese New Year? He says, no, I don't. So do you remember maybe your wedding, which perhaps is in January, or then Christmas in December? Do you remember what you did that time? Then perhaps he says, yes, I remember my wedding, and I remember some bits of Chinese New Year. Okay, so this entire thing where he remembers around Chinese New Year and beyond, in the event and after, if he forgets around the event around Chinese New Year, and he forgets around the ICU stay, this entire thing is called post-traumatic amnesia. So if he forgets event and from the ICU stay, then this entire process or this entire period is called the anterograde amnesia. Okay, and if he forgets from the event to Chinese New Year, that's the retrograde amnesia. So this entire process, this entire length of time is actually called post-traumatic amnesia, which could include retrograde amnesia and anterograde amnesia. Now, most patients, as they recover, you can see that they will have some memory coming back. This time frame will become shorter and shorter until most of the time they don't quite remember the event. They start remembering islands of memory. They must remember, okay, they may remember what they did around this, but they cannot remember what time they went to their family's house. So the islands of memory come back. Okay, but once they form continuous memory, that means they completely remember Chinese New Year, what they did before, when they went and bought the crackers, firecrackers, what they had, what kind of food. That's continuous memory. So once they remember all of that, then they can start forming new memories and start remembering better. So this is applicable mainly in moderate and severe TBI, but can also be used in mild. Okay, but usually PTA doesn't last that long in mild. Okay. So, like I was saying, now if your patient has all the symptoms of PTA and he doesn't score 18, and you need to send him home, you can send him back with a brain injury advice card, so you can ask them to see the ones in red, what are the signs, like fainting or blacking out or feeling drowsy or vomiting that persists. Come back to the ED or come back to go see your KK or whatever. Okay, and you should anticipate that your symptoms should improve after 2 days, and it should get even better after 4 weeks. Okay, So if you don't get better, you need to seek help. Your primary care provider. This is another one. This is provided to us by the CDC. You can use any of these, are also available freely for you to use, or you can design your own. Okay. It also tells you on how to feel better and to get better. Okay, so now let's move on to what is cognition. The very fact that you're listening to me and trying to understand and trying to decipher all the lectures that you've heard before this and trying to perceive and trying to react to it, because there's an input, you try to process, you try to understand, then you try and store. You store all of this information. Once you've stored it, you try to retrieve it. And with this information that you have, it helps you make better decisions and produces a response that's appropriate. Entire time you're filtering whatever that is trying to interfere with you focusing. For instance, there'd be noise around you, you just block those noise out. Or if there's a phone that you want to use, then you realize that you want to listen to this part, you ignore your phone or you put it on silent, okay? Something like that, okay? So cognitive domains tend to be the 5 main ones which are attention, memory, executive function, perception and praxis, and language. So we'll just dwell a little bit on this, just 1 or 2 slides each, so that you can understand things better, okay? So attention is divided into focus, like you want to focus when it's a lecture, you're focusing, like now. Sustained attention, you can carry out this attention for longer periods. Selective, like you're in a very crowded environment and like you're in a football stadium and you're watching a football game. It's so noisy, but you really focus on the game that's going on, where the ball is going from one place to the other. Divided attention is more like multitasking. Memory, you can have sometimes, you remember where things are placed in your room. You know that your computer is here, you know where the vase of flowers is, okay? You know where your books are, you know where your glass of water is, the specs is kept. So that's your visual memory, okay? Auditory memory, you remember what your mom said about this many years down the line because you remember those words are important to you. Working memory is almost a memory being formed. So let's say you listen to something, it lasts for 2 seconds, but you want to make it work for you. So this working memory is a process of paying attention, storing information, and coding it so that you can retrieve it later on, okay? So executive function is where this is that CEO is telling you about. It creates an action, it has an initiation. It helps with processing a certain amount of speed, the way we think, how fast we think. It also uses, it's good at problem solving, managing a jigsaw puzzle, and it plans. Let's say today you decided that you want to go to Singapore tomorrow because there's an urgent thing that's come up. So you have to start planning. How do I book my tickets, or do I drive down? Do I apply for leave? Do I have enough money? How long am I going to stay? Where am I going to stay? So all of these are planning, and you have to problem solve on how to get to Singapore, right? So this is the executive function, which is mainly in the frontal cortex. Okay, so if there's a cognitive impairment, there's the impaired ability to carry out your normal activities of daily living. It can be because of a brain injury. Of course, you say more in moderate and severe, but it does not spare the multi-PIs. Okay, so we already talked about of attention, what it looks like. But if there is a problem with attention, then you'll be a bit slow. You get easily distracted. You tend to neglect what's going on. You become impulsive because you can't keep your attention, much like a child with ADHD. They can't keep their attention, so it's very short amount of time they spend for attention. Therefore, they become very impulsive. Little while they're doing this, little while they're doing that, so they just can't focus, okay? So that's the problem with attention. So how would the patient present? So they're unable to filter out. So because they can't filter out external stimuli, they're unable to carry out self-care or take care of themselves. And they will appear to be irritable, okay? They miss out details in everyday work if they have attention issues. So therefore they're stuck in their coursework, in their work, in their assignments. This is multi-PI, okay? And it appears to the person managing them as lazy, and whatever they're supposed to do, we have to help them. They can't focus. So if they go to the physio gym, they become distracted. So, and people will say they look at other people all the time rather than focusing on their work. And they can't keep into normal conversations. If a lecture is going on, they get lost. They require repeated instructions, okay? And their reaction time is too slow, so they take time to complete their assignments. And their friends will feel it's faster to do it for them. Okay, then the next problem is memory. As you can see, how's your memory holding up? Yeah. Okay, so short-term, long-term memory. We both know this. So short-term helps you to encode. And we all know about the short-term and long-term. So short-term helps you encode, and then they store it back. And when you need to use it, they retrieve it, and it comes out into your current memory or short-term memory. Much like your computer, you store up all the files, and then you try and retrieve it. Remember, your computer or a PC is really it's designed to try and replicate the human brain, okay? Yeah. Okay, so how do they present? They cannot remember. They're unable to learn. Day-to-day memory is a problem. Learning new things is a problem, okay? So then it's executive function. I really like this cartoon that's here. This is child who's received this Lego, and he knows on the box he's supposed to build a castle, right? So he starts representing in his brain, this is what it's supposed to look like. So then he starts planning, okay, so I'll put this here, puts it there. Then he should go like this, look at the instruction, then he starts executing his plan. But once he executes it and he evaluates himself, okay, wait a minute, it's supposed to look like a proper castle, but it looks like this. So this is very important, when we need to plan, do action, and then evaluate, okay? The same thing, we're doing it all the time, and we don't even realize it. So if there's a breakdown in any of these processes, then you can see that the result is different, okay? So for instance, a patient will have a problem with planning. He's unable to plan. So if you give him, so tomorrow you need to go to Singapore, the same scenario, you need to go to Singapore, he won't know what to do. He will be stuck and perhaps, okay, I need to go, but I don't know where to stay. I don't know how to plan that. And once he knows he's going, maybe he knows how to plan, but he can't execute it. All right, I want to go, but I really don't know which one comes first. Okay. And he doesn't have the ability to see where he went wrong. So any one of this can break down if you have multi-BI. And then what's initiation? So initiation is that you have an idea, you form a link to an action plan, you carry it out, and then you monitor and see how to resolve it. Okay. The entire time you're using your memory to link up all your plans and you carry out this action that you plan. And each time you try, the brain is inhibiting excess information and stimuli that doesn't belong to the idea, the action, and the execution. Okay. Okay. So now that we have all these symptoms, we have these cognitive issues, we have headaches. Which one do we treat first? Okay. So when they come to rehab, once they refer to us, the first thing we do is we look at what is the main things that are causing them discomfort. Usually it's the anxiety, irritability, sleep, and headaches. We tend to deal with all of these step by step. Okay, and then we also try and deal with the other issues that come. Once we've managed all of this, then we go on to physical activity to help them with their balance, with physio, dizziness, or even with tiger issues. And then we treat them for cognitive and fatigue issues. Okay, so then you might wonder, how long does this phases take? So if the patient is there with you, you can advise them within the first 4 weeks or maybe 2 weeks that they should get a lot of rest. It's going to be fine. You stay away from much medication. Don't medicate yourself. Just get lots of rest, and then we can give you some medical certificate for you to rest. Okay, and then between 4 to 12 weeks. Understand that if your symptoms don't become better, then you should be referred to an interdisciplinary clinic, much like what is run in most rehab centers. Okay, what will they be focusing on? Like I discussed just now, your headache and mood, fatigue. Okay, and then the goal is to get you back to your previous life activities. Okay, and if at 3 months you're still having all of these symptoms, then you really need individualized management. It has to be structured by the interdisciplinary team to manage one by one. Okay, again, the focus is pre-injury activities. So what is post-concussion syndrome? So resulting from a concussion, or also known as multi-BI, it persists beyond 1 month, and some literature says 3 months, but most of the time people are changing it to more than 1 month now. So what does ICD-10 say? So it lasts for a maximum of 4 weeks of history of head trauma, loss of consciousness, and any symptoms after that last for a maximum of 4 weeks. Any 3 of these symptoms that the patient has below would indicate that he's got PCS. Like we discussed, headaches, dizziness, malaise, fatigue, change of tolerance to noise, irritability, anxiety, memory issues, any cognitive issues, reduce alcohol tolerance. Okay, that means if what normally a person can drink, let's say 3 cans of beer at night, and he's a social drinker, he can't even tolerate one can of beer before he becomes confused. Okay, and then they become very preoccupied, very anxious about what's going to happen to them. And the symptoms we already know, the most common is headaches, dizziness, and concentration. And cognitive issues can be working memory, flexibility issues, they have inhibition issues, and verbal problems. Okay. Any one of these may be a problem for them. Attention, processing speed, emotional problems, memory. We've discussed all of these. Okay. So the headaches, usually they present with about 85% of the time, it appears as tension headaches, okay? So it's like a pressure, a dull ache, tightness, and it's constant, always present. They can also have throbbing headaches around the eye area, frontal and temporal areas, or they can have a migraine-like picture, okay? May not have a full clinical picture, but almost like with, or may not have aura, but it's throbbing as well. Episodic, and maybe associated vomiting, the good times and bad times in terms of headaches. Okay, so these are the common ones. Okay, and sometimes if you do have this whiplash, so they have a lot of neck pain that comes with that, and then it becomes a cervicogenic headache. Okay. Okay, they can also have vestibular ocular dysfunctions, which includes vertigo, motion insensitivity. That means they feel like as if they're melayang-layang. Okay, the gait and the balance is a problem. So they feel like they, even if they're walking and they tend to stumble, tend to fall. They have diplopia. Okay, so the other thing is that because you notice that most patients have cognitive issues, they have headaches, you would advise them to refrain from driving, especially because then they have problems, with their thought process. It takes time for them to react, and then they get lost because of their memory problems. So let them not drive for some time. If you want, you can let us do that driving assessment so that you know when it's safe for them to drive back. Okay. So usually a multi-BI program in any setting would include support, education, advice, and we try and help them return to their previous right roles. Okay, we track their symptoms, we help them monitor compliance with their treatments and their outcomes. Remember, we're people of function, so we connect them to work together as a team to help them. Remember, we discussed initially, our goal is to return them to previous life, their goals usually previous life roles. So we work together as a team with that common goal. So usually there's a physiotherapist, occupational therapist, psychologist, and audiologist would work with a multi-BI or PCS patient. Okay, we usually monitor them right up to 6 months, 1 year, sometimes 24 hours, depending on their need. We gradually improve. As they improve, we gradually make things more difficult for them. Like it's like playing a game. You start off at level 1. Once you do well in level 1, we get them to level 2. We sort of make it level 3 and more difficult until they get to that previous role that they were in. Okay. Okay, improving general well-being. So we find that getting enough sleep will and sort of like help with cognitive recovery. Managing their stress also helps them concentrate better. Giving them regular exercise. We're not talking about jogging because or anything that is contact sports. We were talking more of just aerobic exercises, simple walking would help them improve blood circulation, helps with endorphin release, and will help with the headaches. Internal endorphin release would actually help with their headaches. Okay, walking outside, looking at greenery helps to soothe as well. relaxation techniques that can be taught by either the occupational therapist or the psychologist, okay? Or you can YouTube relaxation techniques. We prescribe them with a certain amount of medication. We don't want to give them things that can impair the cognitive further, like tramadol can impair cognition, okay? So can morphine, that would also lead to physical, psychological dependency. We don't want them for them. That for them, we prefer Panadol, or if at all, the headaches could become worse, than a neuropathic agent or an adjunct like gabapentin to help them with their headaches, okay? We want them to avoid alcohol, cigarettes, and drugs at all costs at this point, okay? Gradual return to alcohol can be introduced, but much later. So I replied, after dealing with Miss C, we managed her according to what we discussed entirely throughout this lecture. So you can see our response to Dr. MB. So thank you for trusting us with Miss C. Yes, indeed, she has post-concussion syndrome. Why? She has more than those 3 symptoms that was discussed and defined by ICD-10. Okay, symptoms were quite a few. We decided to tackle sleep issues first because that was a basic need. Okay, the concept of sleep hygiene was introduced. So what's sleep hygiene? Reduce caffeine intake and reduce it to maybe just 1 and nothing after 6 p.m. Okay, light aerobic exercises like we talked about earlier to promote physical tightness, and she will want to sleep. Sleep early and on schedule. Reduce the use of devices at least 2 hours before sleeping. Encouraging her to read a book instead, because reading a book is easier to doze off. Okay, and she was compliant to this. She followed all of this, and this helped her get a good sleep, and she felt very refreshed the next morning. Okay, it improved her attentiveness at school, and her headaches began to reduce. Okay, and because of the exercise and the sleep. We then introduced her into putting up a structure in the daily routine. So she knew that every morning she would have to have her classes, and then she'd have in the evening she would have to have a balanced diet during her mealtime, and scheduled exercises and scheduled social outings so that she can overcome her anxiety. She was also encouraged to avoid alcohol and driving for a while. Okay, her headaches, for her headaches, because she was in a great pain cycle, she had headaches almost every day. We gave her regular paracetamol to help her break off her pain cycle, which means she couldn't wait for her pain score to be around 8. We encouraged her to take the paracetamol following the 8-hour regime. And even if her headache was 4 or 3, to take the paracetamol, so that, because the general understanding is that if you are in pain, your pain score is 8, then take a paracetamol then. But the problem with that is, if you're going to advise your patient, the problem with that is if in normal chronic pain strategies, the problem is that is if you take a pain medication at a pain scale of 8, then it'll take time to come down to 6. And then you need to take another dose, and you're still in pain, another dose of paracetamol, then only it comes down to 4 and 3. Okay. Now, if your pain score is around 4, and if you take the paracetamol at 4, at a pain score of 4, you'll go down to 2, and you can be pain-free for quite a while. And you can be functional, you can focus. So that's what happened to her. She could focus, and she could perform better at school, at college. So we worked on her cognitive issues next. She was assessed by a neuropsychologist. Now, if you don't have a neuropsychologist, it's fine. Clinical psychologist also works, as well as an occupational therapist will work fine. Okay, and they found that she had problems with fatigue in terms of cognitive fatigue, emotional fatigue, and physical fatigue, 3 types of fatigue. She had problems with attention and slow thought process, and she had mild anxiety with regards to post-concussion syndrome and its effects. She was classical, and she received psychoeducation. That means they explained to her what PCS is all about and what her symptoms are, and she was taught on how to manage her negative thoughts. A bit of cognitive behavior therapy was taught to her, and some relaxation techniques. Then her occupational therapist worked with her on energy conservation techniques. What does that mean? That's a way to manage fatigue. Let's say you know that you'll do well the first part of the day before you become very tired at the rest of the day, in the afternoon. Do most of your work during the first part of the day. Okay, so that means schedule most classes during the first part from 9 to 12, where you're most alert. Okay, So if you know you're going to go for a major event like a wedding, so then you know you have to store up on energy and not to waste that energy during the day or the week, the days before the wedding. Store it up, get enough of rest so that you can spend that energy during that wedding, because you know the next day you'll be in energy deficit. So planning, knowing when your energy excess is and when energy deficit is very important. It's much like spending money. Okay, all right. So then she was also taught to record her lectures with permission of her lecturers, of course, record her lectures and play it back so she can focus better, focus and play and stop, making notes so that helps with her memory. It becomes a visual memory for her. It helps her encode. She was taught how to break her topics down to smaller ones, to master smaller topics first. Okay. And then we wrote into her lectures to allow her to have extended deadlines for assignments, and also asked for shorter classes per day and to adjust her timetable to reduce information overload, to promote attention, memory, and improving in thought process. So it's been 6 months now. Since she's been in our program, she's improved tremendously. We've also assessed her driving ability, and she's safe to return to drive. She's advised to return. She's allowed to return to jogging since her headaches no longer trouble her. She's reduced her social drinking to just one glass only if she goes out. She handles normal class loads now, but she knows she needs to spend an extra hour compared to before her fall to manage everything. She has a normal sleep pattern. Her headaches have reduced to once a month. So thank you for your referral. It was a pleasure to work with EC. And these are my references. Thank you so much, everyone. And I hope this lecture was helpful for you. Have a good day.